I just want you guys to know that that is something that you need to think about over the next couple of weeks, and maybe some of those things you have planned, maybe they fall off your calendar until the middle of February, just because these next 2 weeks will take a little bit more time. Make sense? Okay. I am recording. Perfect. Okay. So, my camera though. So when we talk about cardiovascular focused assessment, there's a very key point I want to make. I'm a wanderer. You guys really have time me very much for that too, so don't let that. There are a lot of cardiac diseases, right? Name a couple. Hypertension. CHF, right? COPD. COPD affects the heart, but it's respiratory in nature. Coronary artery disease. Okay. Coronary arteries are where? Around the heart. So that means that coronary artery disease is specific to the heart, not the whole body necessarily. So if you have it in your heart, you probably have it everywhere else too. What else? What? Congenital defects, absolutely. Things babies are born with in their hearts that more often than not have to be repaired. Like heart murmurs. Heart murmurs, sure.
Cholesterol, would cholesterol fall?
Cholesterol would fall under this.
Heart blocks.
Heart blocks. Cardiac arrhythmias. Vascular disease, things in the vessels that cause ulcers. Okay. So what I want you to take away today, because this is building our foundation for the rest of our diseases, is learning how to do a good cardiac assessment. Because it should not matter what kind of heart disease or cardiac disease your patient is experiencing. What's going to matter is, can we recognize there's a cardiac problem and can we intervene appropriately? Does that make sense? Okay. So that's what we want to talk about. So, technology. Okay, so cardiac focus assessment, okay? Detailed look at the heart, okay? Now, because the heart affects the whole body, even though it's focused on the heart, am I going to be asking a lot of things about what's going on with the rest of the body? Such as trouble breathing,
Pain.
edema, pain, chest pain, fatigue. Good. Those are just a couple of big ones to name a few. Okay. We're looking at subjective data. What is the patient telling me? They're telling me they're feeling kind of short of breath. They're telling me they're experiencing chest pain. They're telling me they've been more tired than normal. My objective data, right? Then what am I getting in my assessment that would support that? If they're telling me they're short of breath, what will I find objectively? Higher respiratory rate.
High blood pressure.
What?
Blood pressure.
Yeah, higher pulse. Who said something?
Blood pressure.
Right, lower oxygen level. Somebody up front, does it bring that? What'd you say?
Blood pressure.
Blood pressure? Yeah, elevated blood pressure, right? Typically, maybe it's lower too, could be something else. Good, okay? We're gonna talk about history, because there's a lot of things in a person's history and the questions they answer that point us in the right direction of heart disease, because heart disease isn't gonna be the same for everybody, okay? The questions they answer might say, okay, we're thinking hypertension, or we're thinking congestive heart failure, or we're thinking some kind of infection of the heart, or we're thinking some kind of long-term chronic, whatever it is, vascular disease that's going to lead to them needing to have an amputation of their foot, okay? That's all affected by the heart. Risk factors. We've talked about this a little bit before, okay? Give me some risk factors specific to cardiovascular.
What's that?
Age. Family history. Diabetes. Ethnicity. Diet. Yes.
Their weight.
Their weight. Okay. Patients who are heavier, African American or Hispanic. Okay. Your men. Family history of any kind of cardiac disease. More likely to have developed some type of cardiovascular disease. Whether that's hypertension, heart failure, etc. There's a big genetic component. Okay. Especially with hypertension. If you have hypertension, there's risk for bigger problems. Okay, high blood pressure doesn't seem like it's that big a deal, but it starts with high blood pressure and ends with heart failure, ends with renal failure, ends with death, right? Cardiac arrest. Diagnostic testing, okay? Those of you that did your sim last Friday, and then there's a group coming this Friday, and then some other groups coming, okay? We talked about this a little bit already, okay? We'll talk about this some more in the sim lab. We're gonna talk about it. It's on the recorded assessment video I made for you. We're going to talk about it a little bit in here. Okay. There's different diagnostic tests we do for different types of heart disease. Makes sense, right? Okay. Then we have our physical assessment. I think you guys have that pretty down pat. If I said go do a focused cardiovascular assessment on somebody, this is part of it. You could go in and do that, right? Figure out what you're looking at. The hard part is figuring out what kind of questions. How are we going to adjust our questions for this? Lastly, cardiac rate, rhythm, blood pressures, all that's going to come into play. So the reason we have to do such good focused assessment, not just for cardiac, but for any system, okay? Cardiovascular disease is the #1 cause of death. Did you know that? So many risk factors. Some of them are modifiable, which means what? We can change them, right? A person can change their weight. They can change their diet. They can change their activity level. They cannot change their family history. They cannot change their ethnicity. Okay? They cannot change their biological sex. Okay? They can change their gender. But becoming a transgender doesn't take away your risks for that biological sex component of cardiovascular. Make sense? It can increase the condition of having cardiac issues because of all the hormones that are changing. Absolutely, that's a really great thought. Okay? You guys catch that? Hear what you said? I told you, I said biological sex, okay? What they're born as, male or female, they can change their gender. They can have transgenders or gender assignment surgery, but that doesn't take away those initial risk factors that come from that sex at birth. Yeah. And becoming a transgender actually will increase your risk of cardiovascular disease because of all the hormones and the medication involved in that type of surgery. Make sense? Okay. Yes. This one is not posted yet. Oh, it's going to be interactive. Most of the stuff should be in here. Yes. No, you're not missing something. I'll post it after class. Okay. So the thing with the focus assessment that's really good is it helps us find patients who are at risk. In this room, okay, let's think about it. How many of you, if you're being honest with yourself, think you might be at risk for cardiovascular disease in the future? A good number of you, okay? Yeah, put my hand up, okay? Questions like this can help us figure out what we need to do to prevent, because that's going to be our first goal, right? Prevent, don't let it get worse. Stop it in its tracks altogether. Not everyone that has cardiovascular disease has to be medicated because it can be managed with lifestyle modifications, right? Potential causes, changes in patient condition, and gives us an overall look at our patient's medical condition. So what we're going to do is we're going to talk about focused cardiovascular assessment, okay? So this is Janica Mills. She's a 4-year-old female. Looking at this picture, okay? Talk about it in your little tables for just a quick 2 seconds, okay? What are your initial observations about this patient? Can we turn the lights out a little bit? Look at that. No. All right, fire away. Initial observations. What do you see?
African American.
African American.
Flaring nose.
Oh, yes, it looks like her nostrils are flaring. Okay, why do you think that is?
She's
Having trouble breathing.
already in the hospital.
Already in the hospital. Kind of pale.
She's not smiling.
She's not smiling. She doesn't look happy. She's young. What did you say?
Lethargic.
Yeah, lethargic. She looks a little bit lethargic. Okay. What potential problems with the heart do we automatically start to think about for our little Jenica right here, based on the things you've said? Something congenital, right? She's young, so maybe something she was born with. Okay. Congenital heart defects. Do a lot of them lead to congestive heart failure? Yes, a lot of them lead to congestive heart failure. Okay. So in this case, she is diagnosed with an atrial septal defect. Anybody care to take a gander at what that is? Nope. Atrial septal defect?
Whenever the middle of the heart is closed.
Kind of. There's a hole between her atrium. Atrii. Okay. Yes. What?
Not closing correctly.
Yes. Yep. When it's really small, most kids are symptomatic or asymptomatic. They don't have any symptoms. Okay. If the hole is bigger as the kids get older, the symptoms become stronger. So we're looking at things like development of CHF, exercise intolerance, extreme fatigue, difficulty feeding. They're usually smaller in stature. Why do you think that is?
They're not developing.
Circulation, they're not developing. Hard for them to do those basic things like eating and growing because their body's in such high demand because the heart's working so hard. Okay? So, my next question about little Jenica, knowing she has an atrial septal defect, okay? What signs and symptoms might we expect to see with this?
Chest pain.
Maybe some chest pain,
Trouble breathing.
trouble breathing, tiredness, fatigue. Does she look tired? She does look
Laying
tired.
down.
She's laying down, yeah. I mean, she's in a hospital, but
Would you have tachy or bradycardia?
ooh, good one. What do you think? Tachycardia or bradycardia?
Tachy because it's trying to compensate.
Tachy because trying to compensate. She might. She might have low blood pressure or high blood pressure. It might depend on the seriousness of her condition. So she would probably have weak pulses. That's good. Yes.
Would that increase the cardiac workload? Or
Increase the cardiac workload because the heart's working harder. Okay. And not just the heart, but the lungs. So if you have an atrial septal defect like that, that can affect how the blood is flowing. So think back to anatomy and physiology, the circulation of the blood through the heart. Okay. It's altered. So it's not doing what it's supposed to. So you might have unoxygenated blood in places there's supposed to be oxygenated blood, and oxygenated blood in places there's supposed to be unoxygenated blood. That changes everything, right?
Mhm.
Yeah. Okay. So how will we tailor our assessment to this 4-year-old girl based on what we know? What are some things we would do? Like what kind of questions would we ask this child, parent, her caregiver, etc.?
Family history, first of all.
Family history, absolutely. If mom has a congenital heart defect, child's more likely to have one. Okay, definitely pops to genetics. What?
Problems like with activity level, like respiration, like if they're like they can't exercise during PE or like it's
Right.
too much for them.
Right.
How they tolerate the mother's pregnancy.
Yeah,
She's
how was the
small.
mother's pregnancy? Yeah, what happened in pregnancy? Because sometimes that can happen. If there's a problem with mom during pregnancy, it can lead to the development of congenital heart defects, for sure. When was she diagnosed? How long have they known about this?
What's your diet like?
What's her diet like? Yeah. And you guys were commenting on activity. A really good question I might ask. What does she do day to day for her activity levels? 4-year-old kids, what do 4-year-olds do? Play, run. They don't stop, right? Yeah, they don't stop. They don't want to take naps anymore. They don't want to sit down and eat. They don't want to sit down and watch TV. They want to go, go, go. They are into everything. Okay? So kind of like 2-year-olds, except a little bit bigger.
Would they have problems like with anemia because of the like oxygenation?
Good question. They might. They might have problems with anemia. questions?
Fix it.
Can we fix it? Yes, we can. She's being admitted for ASD repair, and they're going to do it in the cardiac cath lab. They're just going to put a patch over it so that the blood will return to normal circulation. So cardiac cath, is that a major surgery?
Yeah.
It's a procedure. It's minor. Okay, cardiac catheterization, pretty minor. So in case you're not familiar with the cardiac catheterization, they take a small tube. Telling the sim group the other day, it's not quite as big as my pinkies, so it's not teeny tiny, okay, but it's bigger than your typical IVs, maybe the size of a pencil, okay, and they put it either in the groin or in the wrist, and they thread it up to the heart, put some dye in there. So if your person or a grown-up, if they have a heart attack, myocardial infarction, they'll do this to see where the blockage is that caused the heart attack. And then they'll try and open it up with a stent, okay? With this same procedure, they can also repair congenital heart defects. They can do all kinds of things. So not a major surgery. They're not cutting her open. They're not putting her under anesthesia, okay? She's getting light sedation. She'll be mostly awake, and they'll do the little surgery, right? That doesn't sound so bad, does it?
What is the procedure called again?
Cardiac catheterization.
Isn't your chance of surviving like a heart attack or I don't know, maybe a stroke better if you have a hospital with a cath lab?
Absolutely, it's better.
Isn't there like some type of, I don't know, like necessarily like a time frame, but
There's a time frame. They would like them. In our area, we can't do it because we're not close enough to a cath lab. If they're in a hospital with a cath lab, they want them from the time they come in the door to the cath lab. They want them in an hour. In an hour. Okay. For us in this area, we're probably looking at 3. We get them in 3 hours. We'll call that good. That's a win. Because where's the closest cath lab from here?
I want to
I
dodge.
want to dodge.
You have one in Dodge? Awesome. We might hit an
They
hour
don't
now.
always have a doctor.
They don't always have a doctor to do it. Okay. I did not know they had one in Dodge. That's great. Great news. Okay. Dodge, Wichita, Amarillo, where you're going to send them. Because Dodge doesn't have the ICU if something goes wrong. So they have a cath lab. Okay. They might need an ICU for this kind of complication. Sometimes they get to a cath lab and they're like, oh, we can't fix this. We have to take them to surgery. So they have to go to have open heart surgery. Okay. Same would be true for this little girl. But fortunately for us, because I wrote this story, okay, she comes out of surgery just fine. Okay? She has her heart cath, her things repaired. Okay? Knowing she's coming in for surgery, knowing she's 4, knowing some questions we need to ask, okay? What else are we going to do with this assessment that we might not do with an adult? Think your pediatric assessment. The way we talk to them. A 4-year-old who's been unwell all their life, do they probably know more than the average 4-year-old about their body?
Yeah. Probably include them in the assessment.
Probably include them in the assessment. Listen to them, absolutely. Okay.
My daughter has a teddy bear that's had open heart surgery, like she has, and she got it at the time of birth. And every time she has a procedure, she uses her teddy bear and they show her.
Show her what they're doing. Yeah, that's a great idea. I've seen that a lot. Use of stuffed animals to demonstrate and educate children. Least intrusive to most intrusive. Think about the parent. What about the parent? Question them. Yep. Yeah, because the patient probably doesn't know if she's not acting like a normal 4-year-old. If she's napping all the time, the mom would be, oh yeah, she naps 3 times a day. That's not normal for a 4-year-old. That's not normal for a 2-year-old, right? So knowing that, knowing some of those developmental phases from our developmental psych courses, okay, we can kind of get an idea of what we would expect a healthy 4-year-old to act like and see where she doesn't quite fit and how we're going to adjust our assessment to that. Because if we find something that doesn't fit the normal, right, we're going to ask more questions. Physical assessment, okay? What are we going to do about our physical assessment? Listen to her heart. Her lungs too. Check for edema in her extremities.
Would you check to see how much activity she can do before she gets tired?
Yeah. Maybe stress test. She might get a stress test. Okay, stress test. Okay.
Yep.
That refill, that's a great one. Absolutely, we want to see that circulation. We know there's circulatory issues. We're gonna check all of her pulses, right? Head to toe. Check her cap refill. Touch her skin. Why? See if it's cool or hot. See if it's cool or warm. Absolutely. We know what the temperature is. If it's cool, what does that tell us?
Like the circulation?
Poor circulation. With her condition, do we expect poor circulation?
Yeah.
Yes. Probably want to do an echocardiogram on her. Absolutely. That's a great lab to do. That's an ultrasound of the heart. Tells us the functioning and shows us the path of the blood through the heart. We'll look at the fingernails. What about the fingernails? They can change shape. They can do what they call clubbing. It shows lack of oxygen for long periods of time. People that have clubbed thumbs or clubbed fingernails, I don't have a picture of it. Sorry, you'll have to Google that one yourself. They have some sort of underlying condition. So you see a lot in asthmatic children and children that have congenital heart defects because their body gets used to running at that lower level of oxygen. Doesn't mean we want them to stay there though, right? Just because they're used to it.
Most older people have them like that.
Most older people have it like that too if they have any kind of underlying condition. Okay? So because of this patient's condition, do we have any other potential problems or concerns we might want to assess for? What? Sure, pulmonary edema. If her lips are blue. Yeah, just having any cyanosis. Mm-hmm. DVT, deep vein thrombosis, we're checking for clots. Any psychosocial concerns for a 4-year-old? Like what?
Is she happy?
Well, she's not playing in the, like, she's not active, she's not like a normal kid, so she might not be like in the playground playing around,
Right.
not socializing.
Yeah.
Normal.
At 4, most kids are getting ready to start preschool, right? If they haven't started preschool yet. Okay. Maybe she didn't go to daycare because she was sick a lot. She's tired. Her medical condition needed someone there constantly watching her. So we might have some decreased socialization. Sure. PTSD, yeah, trauma from the procedures and the health that she's had. She might be terrified to go to the doctor. Terrified every time she goes, they're going to put her under for surgery, right? What else? Anything else you would add?
Anxiety.
Anxiety. Yep. Her knowledge, that's a great one. We want to assess her knowledge of what's going on. Does she understand what's happening? Does she understand this is going to fix it and in a couple of months, she should be able to run around and play and not need to take naps all the time? Won't happen right away, right? But it will happen. That's the goal.
What are the chances of making that? I mean, like, how long will it last forever, or does you?
I have to think for a second. With ASD, I think they're pretty solid. So when they repair those the holes in the septum, what it is, so along the heart, they're usually pretty good. They should be ready for their surgery. Yep. All right. Next patient. Okay. This is Sophia Rossi. She's 32 years old. Visual observation. Pregnant. She's pregnant. Is she a little bit pregnant or a lot pregnant?
A lot pregnant.
A lot pregnant. What else?
Her ankles are small.
Her ankles don't look terrible, right? Doesn't look in distress.
She doesn't look like she's gained much weight.
Doesn't look like she's gained any weight. We hate Sophia, right? She has big, like, size. She might be tall. She does look like she might be tall. She's probably like a size 11. We think she has size 11 feet. According to our assessment, yes or no?
No.
No, but a good observation. She's smiling, right? Okay. So if I told you that Sophia Rossi, you said she's pregnant, what potential cardiac concerns do you have for her?
At this moment, nothing, because she doesn't seem like she's in distress.
Doesn't seem like she's in distress. Doesn't seem, okay? But is there still some potential cardiac concerns that we need to monitor? Think through your OB.
Hypertension overload.
Fluid overload, what? Preeclampsia, right? We're really concerned about her blood pressure. Especially the more pregnant you get, the more your chances increase for preeclampsia, even if you look good and feel good.
DVT.
DVT, right? Clots. Okay. She is 37 weeks, 5 days, gravida 1, para 0. Diagnosed with gestational hypertension. So she had hypertension throughout her pregnancy. Now what? Now what do I want to know?
Did she exercise through her pregnancy?
Did she exercise through her pregnancy? Intake and output. What does she eat, right? What's her diet like?
Family history.
Family history. What was her baseline, right? What's her blood pressure been? Okay. What else?
Her age has something important too, right? She's closer to
Geriatric.
She's getting into that geriatric pregnancy range if she's not there yet. She's 32 and it's her first pregnancy. Yeah. Is that what you're getting at?
Yeah.
What'd you say? Yeah, we want to know her blood sugar because if she has a 6 times hypertension, there are risks for other things like gestational diabetes. Did you do something about activity? Yeah, is she on bed rest or is she still doing activities? Maybe her feet are laying down all day and this is the first time she stood up for this picture, right? Where she looks like a supermodel. Okay.
She has a risk for edema.
Risk for edema.
Was it before or while she got pregnant?
For hypertension. Good question. Did she have hypertension before she got pregnant or was this only during pregnancy? Any other comorbidities? Sedentary lifestyle. Yeah. It doesn't look sedentary, but some people have really good genetics and don't ever have to do any activity, right? Medication she's taking before pregnancy and currently, right? What's that going to tell us?
Her previous history.
Previous history and what they're doing to treat this gestational hypertension. Okay? So because it's gestational hypertension, let's assume it's only during pregnancy. She doesn't have issues otherwise. Okay? What signs and symptoms do we expect to be present with gestational hypertension? Maybe dizzy?
She would have some swelling, what is she?
She what?
Swelling?
She might. Not necessarily. It's not a guarantee. Might be short of breath.
Headache.
Yes. Might have some headaches, especially if that blood pressure is elevated. So we want to know what? Vision changes.
What's her normal blood pressure?
What's her normal blood pressure and what's her blood pressure right now? Okay.
Side effects of the medication.
Side effects of medication she's taking. Okay. Say that louder. Complications or arrhythmias. Sure. Is she experiencing tachycardia of any kind? Okay. It is a little bit normal for her heart rate to elevate in pregnancy, right? But if it's over 120 all the time, we have a big problem, right? Okay. We want to know that. It is normal for blood pressure to elevate a little bit in pregnancy. Why?
You're working for
You're making a baby. You're making a human. Your body is working hard, and you have a lot of extra fluid and blood flow going between bone and disc. But how high is too high? One 150 is way too high. Over 90. If it hits 140 over 90, they're going to call you preeclamptic. Gestational hypertension would be considered over 130, okay? Or concern for gestational hypertension over 130, over 85, 90, okay? They really still want you to be below 130. But if your normal blood pressure is 110 over 70 and your blood pressure in pregnancy is 129 over 83, not a lot, right? Not that high. Even if it's 135, we're still not that concerned or pregnant. What we want to see is this a continuous pattern? Okay. Gestational hypertension for over 20 weeks is the diagnostic criteria. They were preeclampsia after you had 20 weeks pregnant. She's past 20 weeks, right? 37.5. So what do we think's gonna happen with Sophia Rossi today? Possibly a stress test. You want to do an EKG? She's getting induced today. We're concerned about her blood pressure. And the OBGYN says, you know what? You're 37.5. You look great. You feel great. Let's make you feel better, right? We don't want her to get preeclampsia because she's not there yet. Far enough along, that baby is mostly fully cooked. 37.5, that's pretty good. Baby, for she might hit 38 weeks altogether. Okay, I take her 2 days to push that baby out. Hope not for her sake, but you never know. Her first one. They say it always takes longer. What else? What else do we want to know? What else do we want to do? Blood pressure before she gets induced. What medications might we want to have on hand? We might want to have MAG on hand. Why do we want to have MAG? MAG does not help the blood pressure.
Maybe a little longer so you can get their surfactant level.
Right, it keeps the baby in a little longer so that their surfactant level up. At 37.5, we're probably not overly concerned about the surfactant. They usually after 37 weeks we're good to go. Okay. What's MAG going to do in the event that her blood pressure shoots up really, really high? Stop them if they start to seize. Okay, that's what MAG's going to do. What are we going to do for the blood pressure? Is there hypertensive? Yep. Hydralazine, beta blockers, etc. Okay, we're going to give antihypertensives to lower that blood pressure. MAG stops seizures if she starts to seize.
Would you also have calcium for the MAG to contraindicate like toxicity levels?
If we get toxic, we're going to counteract the MAG. Yep. And we might need to have some pitocin, right? Might need to have some pitocin. Get things moving along. Psychosocial concerns. Support system. Yeah. Who does she have with her? Is the baby's father in the picture? Always a good question to ask, right? Who do you have to help you?
Should you be scared?
She might be what?
Scared.
She might be scared with her first baby, especially having complications.
Like letting her know like the risk and like everything that can happen throughout.
Letting her know the risk and anything that could happen throughout the delivery. Absolutely. Some other lab tests you guys haven't talked about. Do you guys talk about checking the urine for proteins with Amanda? Yes. What would be the purpose of that? Preeclampsia. Should there be protein in the urine?
No.
No, there shouldn't be. So if there's concerns earlier in pregnancy, they'll do a 24-hour urine, but they can also do it in a urine dipstick. So if they find that in that UA that they have protein in the urine, good indicator for us. If the blood pressure is high and there's protein in the urine, we have preeclampsia, right? And that adjusts our physical assessment a little bit. Because then we are really focused on the blood pressure and the effects of the blood pressure, but we're also concerned about the baby, the fetus. Yes. Okay. Good job, guys. Okay. Any other potential problems or concerns that exist because of our patient's condition, knowing she's getting induced today? Freaking out. Okay. Normal response. What? Right. Monitoring fetal heart rate. Just making sense when we're talking about focus assessment. It's different for Janica. It's a lot different for Sophia Rossi. It's different for healthy Sandra. Okay. David Brown, 62-year-old male. Initial observations. Go.
Overweight.
Overweight.
Male.
Male. Age.
He uses a walker.
Okay, you uses a walker. You see the walker in the background. That and a walker.
Activity. He's sitting, so it looks like he's
The activity level.
sedentary.
He's sitting. Yeah, he has a demon. Why do you say that? He does have edema. Yep. His color, what about his color? Kind of red. His fingers are what?
Like pretty pale.
Yeah. If we look closely at his finger and we can see the picture with a little more focus, you might see some concerns in his fingernails. Sure. So, what do you guys think is going on with David Brown? Heart failure. That is our diagnosis. He has CHF. Okay. So if he has CHF and we can see he has edema, he's overweight, his age puts him at risk. What are some more things we need to know?
Is he a smoker?
Is he a smoker? Mm-hmm. Does he have sleep apnea? What do you think?
Yes.
I'd say yes, based on looking at him. Can't guarantee it for sure because I don't know David Brown. Okay. What else?
Diet.
Family history. What'd you say, Brady?
Diet.
Diet. Yes. What is he eating? Why does that matter?
If you're eating a lot of fatty, greasy stuff, it can increase blockages and stuff.
Cholesterol, he could have.
Yep. Eating a lot of fatty, greasy
Sodium.
stuff. Sodium. Where the salt goes, there the water goes. So if he has a diet high in sodium, he's gonna get puffy. He looks a little puffy, doesn't he? He looks like he doesn't feel very good. Yeah. Other complications like diabetes. What? Does he have COPD? Okay, he does not have COPD, but he does have diabetes. And I know this because here's his med list. You ready? Okay, he takes 2.5 milligrams of warfarin every day. What's warfarin?
Blood thinner.
Blood thinner. He takes digoxin 0.125 milligrams every day. What's digoxin for? Heart rate and rhythm. Okay. He takes bisoprolol 10 milligrams POQ daily, also called Zebeta. What's that for? Blood pressure. Yep. Furosemide 40 milligrams PO twice a day.
Diuretic.
Diuretic to pull the fluid off. Is it working?
No.
So we have to figure out in our assessment why is this furosemide not working the way it's supposed to, right? We're gonna come back to that. He takes Losartan 50 milligrams PO daily. What's that for?
Blood pressure.
Blood pressure. So far we have a blood thinner, a heart rate and rhythm regulator, 2 blood pressure pills, and a diuretic. Okay. He's also taking an aspirin, 81 milligrams chewable. Okay. He's taking simvastatin, 40 milligrams PO at night. What's simvastatin? Did he?
Cholesterol.
Cholesterol. Yep. Takes a multivitamin. He has a PRN order for nitroglycerin tablets when he experiences chest pain. And he takes sildenafil 50 milligrams by mouth PRN 1 time a day, 1 hour before intercourse. Everyone's like, oh, great. Had to throw that in there, right? Okay. So based on his medical history, what 3 or 4 or 5 medical diagnoses does he have? Hypertension, big one. High cholesterol. ED is erectile dysfunction. He has heart failure. Okay, because some of those blood pressure pills and rhythm regulators and the diuretics will treat the heart failure as well. Fluid overload, what? Like peripheral artery disease? He might. I don't know. And he has diabetes. Because he takes metformin 1,000 milligrams. By now, twice a day. I forgot to say that one. Okay? He does have diabetes. Okay? So, question. Did the heart failure cause all these problems, or did all these problems cause the heart failure?
All these problems cause the heart failure.
Probably. Okay, and he's had CHF for 5 years. And he's 62. So that would make sense that he's had hypertension for a lot longer than that. Okay, so I'm concerned about his long-term medical history. How long has he been this unhealthy? And if he's this heavily medicated and he still looks like this, okay, what do we need to assess? His diet. Yes, you guys have said that already, but now we have more information. So now we're really going to get into it, right? Is he taking his medication correctly? Yes. Does he have good education about his meds? Because some of his meds together, I don't know if you listened to your farm lecture or not, okay? If he's taking nitroglycerin, which he cannot take. didn't take his sildenafil, his Viagra, that can cause cardiac arrest from hypotensive crisis. Okay? So he doesn't take the Niger all the time, and he doesn't take the Viagra all the time, so he's probably okay as long as he pays attention. I like to think if he's having chest pain that he has to take Niger, he'd probably not have sexual intercourse, but I couldn't say that for sure. That's just a logical step in my mind. Okay? Agreed?
Yes.
Okay.
Didn't we have a discussion where they can like switch positions to where they don't get so worked up?
He can switch positions so they don't get so worked up. Doesn't change the fact that if he's had chest pain and taken Niger, he still shouldn't take his Viagra. Okay?
Is his diabetes under control?
Ooh, is his diabetes under control? How are we gonna find that out? We check his blood sugars,
A1C?
and we're gonna check his hemoglobin A1C, which gives us a look at his average blood sugars over the last 3 months. Okay? That'll tell us a lot. He looks like he has snacks or he hides
He
snacks?
hides them.
He hides his snacks in the pockets of his. One of those. Oh my. Okay. One thing he doesn't have is oxygen, so that's good, right? Okay. What do I want to know about the recliner?
Does it elevate his feet?
Does it elevate his feet?
Does he
How often he's there?
How often he's there and does he sleep in it? What does that tell us?
can't lay down and breathe?
Means he can't lay down and breathe at the same time. So is that a sign of heart failure that's under control or not?
No.
Heart failure that's not under control if he sleeps in his recliner because he can't lay down and breathe. That's a very good point. And how much time he's spending in there. Okay? How much time should he be spending in there?
Couple hours.
Probably. He's in his 60s. If he's that unhealthy, we don't know if he can work or not, right? That might be something else I want to ask him. Okay? Might want to know about his environment. Is he retired? What did he do for work before? Because maybe that could have contributed to some of his medical conditions. His support. His support. Does he have help?
His psychosocial status, because if he's depressed, he's not gonna move around and do anything.
Fair enough. Okay. You want to know about his support system? Is he depressed or not? Okay. Since we're talking about sex and he has a prescription for Viagra, okay, does he have somebody to have sex with when he wants to have sex? That would be important for sexual health, which is a big part of it, even though he's not a healthy human being. Okay, sex still matters.
If he is, who takes care of him? So his doctor tell us if his meds are under control or not?
Right. Who takes care of him, and do they know how his meds are supposed to be given?
It really doesn't correlate, but how's his hygiene?
His hygiene. It does correlate. Why do you ask about his hygiene?
He's diabetic.
Because he's diabetic.
Like, is he keeping dry?
Oh, yeah. Where is he keeping dry? Where do you want to be? In between his flaps, right? His folds. Okay, he is heavy. We don't want him to get any yuckies growing underneath of there because that can ruin his skin integrity, which leads to more infections. Don't laugh at my terminology, guys. You know what I'm talking about. It helps, doesn't it?
Well, even like his
Now you're thinking about
nails
yuckies.
and in between his feet, right?
Especially his,
Right.
his toes. Can he actually see his toes?
Can he reach his toes?
It also could tell you something about his activity level.
Tell you something about his activity level too, based on his hygiene.
Does he have neuropathy?
Does he have neuropathy since he has diabetes? If he has neuropathy from his diabetes, and he has hypertension and heart failure and possibly edema, does he have some vascular damage as well in his legs? Okay, how's his sensation? Does he have open sores? I want to know that. I want to know about his edema level, right? We can see he's got edema here, okay? Likely he has it. Yeah, probably worse. Especially if right now his feet look like they're dangling. But that's the closest I could get on the whole picture. I couldn't actually see if his feet were propped. But they should be. Good. Very different assessment we did on him than we did on Danica and Sophia, right?
Yeah.
Is this making sense? Focused cardiovascular assessment? Okay. We're tailoring to the patient's needs based on our observations, how they answer our questions, what we know about heart disease. Okay. Donna Mae Winters, 65-year-old female. What do you observe?
She's female and over 65.
Female and over 65.
Discoloration.
She does have a little bit of edema.
Discoloration where?
Like varicose
On her shin.
She has discolorations on her face, fingers, and legs.
Feet seem white.
She's wearing slippers.
I'm kidding. Varicose veins.
Do what?
She looks like she's like gold past, like.
Yeah, she looks well kept. Like she doesn't look like she has a hard time with activity necessarily. She's at least getting up and getting dressed. Looks like she's maybe wearing makeup or combed her hair.
Looks like she has like bruises. I don't know if it's my angle.
On her legs.
Yeah.
Good. I'm hoping you guys would catch that because this is really important. Okay, and her you said discoloration on her fingers and on her face. Okay. It's a hospital gown. She's being admitted for something called intermittent claudication. Have you heard that term before? Probably not. Okay, intermittent claudication is when they experience cramping, tingling, burning in their legs with activity. And it usually happens after the same amount of activity every time. So maybe they can walk 2 blocks and their legs start to hurt. So the question then becomes, why are they experiencing this leg pain? Any ideas? It is a circulation issue. No, not deep vein thrombosis. It has to do with the veins and the arteries in the legs, the lower extremities, being damaged from, could be standing too long, swelling, okay, history of disease or trauma. What?
Would it be like hereditary?
Hereditary, and the big one? Smoking. So we want to know, is this patient a smoker? Yes, a 2-pack per day for the last 40 years.
How can she afford it?
Especially in this day and age, right? So she's so skinny, she doesn't eat, right? No. Okay? So her smoking has led to damage of her arteries and veins in her lower extremity. Over time, that damage has led to discoloration and sores, and that intermittent claudication, okay, that pain. So I have another question. Does she have hair on her legs that you can see?
No.
Do they look hairy?
No.
No. Does her arms look hairy?
No.
No. Something else we're looking for. Here we're talking about this tomorrow, we're talking about vascular. Okay? No hair that we can see on her arms or legs. Do the rest of you have hair on your arms or legs? Unless you remove it? Pretty much. Okay, that's pretty normal. Okay? If I touched her legs, what would I feel?
Squishy.
Skin. Cold. They're gonna be cool. Okay? They're dangling right now, they're kind of red. Part of this disease.
Could you feel like their veins protruded a little? Or no?
You might, it just depends. You probably feel edema. Okay? What?
more like with cellulitis.
They can get cellulitis. Kind of that same idea. Right now she's dangling, so her legs look kind of red. She's standing. Part of this disease, if I were to put her legs up and prop them up and elevate them, they get pale. Well, that's kind of weird, right? Major circulation issues. So if I know this is caused by circulation issues, even if I know nothing about peripheral artery disease or peripheral venous disease, okay, doesn't matter. I recognized from the get-go there was some circulation issues. So my assessment would focus on oxygenation and circulation, okay? Because if circulation is poor, perfusion is poor, okay? If perfusion is poor, cells start to die. And if the cells die, what happens? Tissue necrosis. That's what causes ulcers and wounds. You can see she has some sores and bruising on her legs, right? Does this make sense? Are you following? Okay. So this assessment, again, very, very different. What kind of psychosocial concerns would I have for Donna Mae Winters?
She can't go out very far.
She can't go out very far. She looks good. She can probably has the energy and the ability physically to get herself ready in the morning. Maybe she can go to work, but she probably can't stand very long at work. Like grocery store shopping.
Changed her habits.
Right, maybe she hasn't denial since she hasn't changed her habit. Body image issues. Sure. She looks pretty good for 65, I think. She doesn't look bad necessarily, but she's not very healthy.
She's probably just used to that lifestyle because she's probably lived like that she's probably started smoking at a young age.
Yeah. Personal question, you guys have to answer. Anybody in here ever smoked? And quit? Yeah. Okay? Quitting's the hard part, okay? Smoking is what it is. Quitting the nicotine, that's the hard part. So you've been smoking 2 packs a day for 35, 40 years. Is your body ever going to return to what it was?
Yeah.
Maybe eventually.
Don't your lungs after like 5 years?
After a while, your lungs will be okay. But the damage is done, right? Yeah. Yeah. Is that damage going to continue to worsen, even if she quits smoking?
It'll slow down.
Might slow down, okay, but probably we're still gonna have continuous problems with that circulation and getting more wounds and all of that. So when you guys go to the wound clinic, anybody been to the wound clinic yet? Okay, some of you have already. One of the things they treat the most is arterial insufficiency wounds or venous insufficiency wounds, okay, or diabetic ulcers. It's not necessarily, oh, they had major trauma and they have to go to the wound clinic, okay? Oh, they have flesh-eating bacteria, okay? They have arterial and venous insufficiency, circulation issues causing wounds. That's what they're fixing. Interesting, huh? Anything else we want to know about Donna?
What's her diet like?
Yeah, we want to know about her diet. Should she have some special considerations for her diet?
She needs to get the nutrition that
It needs. Yep.
Is there other smokers in the house?
Ooh, is there other smokers in the house?
Like her husband?
she has COPD or
Say what? Right, does she have COPD or edema? Emphysema, yep. Okay. All right, so medication list, you ready? I'm gonna step below it. Chantix, what's Chantix?
Quit smoking.
To quit smoking, okay. Metformin, 1,000 milligrams by mouth, 3 times a day with meals.
Diabetes.
Ooh, what you think of that? Okay. Simvastatin, 20 milligrams by mouth at night. Cholesterol. Here's one you might not know. Gemfibrozil. Have you heard of that before?
Yeah.
You just don't know what it is? Okay. This is for it's a combination of the circulation and keeping the cholesterol levels down, because that's going to be a huge priority for us, is to keep her cholesterol levels down. So her diet to be low fat as well, to help with supporting her disease and her healing. Okay. Ramipril. Heard of that before? It's a blood pressure. Yep. Okay. Clopidogrel. Clopidogrel.
Oh.
GREL. Not blood pressure. This one is for helps with cholesterol, helps with coagulation, but it's not anticoagulant. Does that make sense? Okay. Xylostazol. It's actually a phosphodiesterase 5 inhibitor, which is kind of like Viagra, but it's not for that. Okay? It's to help with circulation. All right. Does that kind of fill in some of those gaps? More things we might ask. More things we want to monitor for. Yeah. This disease is caused by risk factors upon risk factors upon risk factors. People don't just wake up and develop arterial or venous insufficiency. All right. Last one. Hong Win. He's 80-year-old male. Basic observations.
His age and gender.
Age and gender.
So he's not really susceptible to anything, or is he?
Are they the healthiest?
They're usually the healthiest. So the fact that he's 80 and maybe has some cardiac problems might be more age related than ethnicity related. What happens over time? Things work the same way they did before. They decrease.
Say what? Okay.
Medical conditions.
Medical conditions. We want to know his history. He has 0 medical history until today. He says he has no other health problems. Right now, he's experiencing chest pain.
Is he a smoker?
Nope. He looks a little pale.
Was
So-
he doing an activity that caused them to?
Ooh, good question. Was he doing an activity that caused the chest pain? Does he eat a lot of red meat? Yeah, diet questions would be really good here. When did his pain start and can he rate it? Anything help his pain, right? Has he taken anything for it? He has no medical history. He probably didn't have any nitro at home. He probably didn't take that, right?
Did any like major event happen?
Yeah, any major events or stressors? Any recent changes in his life? Yeah.
Like elevation. Doing
Elevation.
like
where he's living. Sure. Yeah, elevation could affect that. Could affect the ability for the oxygen and the blood to carry through the body the way it's supposed to. Yeah. No medications, no known allergies. Ooh, good question. I want to check his labs, right? What kind of labs? CBC. CMP. You want to check his electrolytes? Check his oxygen. If he's complaining of chest pain, I want to get an EKG, right? See what his cardiac rhythm's like. Is it showing any damage? And I want to check his cardiac enzymes. Okay? Something called troponin, myoglobin, CKMB. I want to see what those are. Yes. BNP checks for if they're in heart failure. Tells us the severity of heart failure. Yep. Good. Totally different assessment, right? Now I'm focused on that chest pain. That's my big thing, right? With Janica, what was my big thing I was checking for? What was my biggest concern with her?
Her age.
Her age. And what? Psychosocial. Sure. She's having surgery for a congenital heart defect. Right? Okay. With her, what was my biggest concern? What was my biggest focus on in my cardiac focus assessment?
managing the hypertension.
Managing the hypertension. Yep. And the fact that she was pregnant. I was concerned about her and the baby. With him, what was it?
Heart failure.
Heart failure and all that goes along with that, right? The symptoms of that. With her, circulation, right? That was my big focus, was the circulation. And with him, now it's the chest pain. Do you get what I was getting at? It doesn't matter what kind of heart problems they're experiencing. Can we recognize there's a problem and intervene? Okay? So for Janica, obviously she's having surgery. What will we do in the meantime? Put her on O2, right? Put her on oxygen, telemetry, okay? Pace her activity level a little bit. Make sure she's getting good nutrition because she'll need it, okay? Probably NPO for her surgery, but after that, okay? For her. Induced labor, yep. And frequent blood pressure monitoring. And then anything associated with that, making sure there's no further complications developing, okay? That's what I'm gonna do. It's my big interventions. For him, what's my big interventions? Continuous pulse ox, probably some oxygen therapy, education, and getting rid of his swelling, getting rid of the fluid, okay? That fluid goes, is his heart gonna work a little easier?
Yeah.
Is his lungs gonna work a little easier?
Yeah.
Yep. Her,
Circulation.
circulation, okay? What's my big interventions here?
Try to reduce smoking.
Reduce smoking, reduce her risk factors, treat those underlying conditions contributing to this.
Diabetes is under control.
Yeah, make sure her diabetes is under control.
Low cholesterol levels.
What?
Low cholesterol.
Low cholesterol levels. And improving her mobility, right? Her activity. Her activity tolerance. And for him, figuring out what's wrong with him, what's causing the chest pain. Okay, we're gonna rule out a heart attack first. Okay, maybe this is a one-time thing. Maybe it was something stressful that set him off. Okay, maybe he's having a cardiac arrhythmia that's causing the chest pain. Okay, so we're gonna figure out what's going on with him based on the testing and assessments that we're gonna do. Do we need an order to do an EKG?
Yes.
Yes, technically, but if we're in an emergency and we get an EKG, is the doctor gonna be upset? No. If we're in an emergency and we order labs, is the doctor gonna be upset?
No.
Maybe more upset than the EKG. The EKG would be our priority. Okay. What kind of medications can we give him? Aspirin, nitroglycerin. Okay. Most hospitals or healthcare facilities will have something called a chest pain protocol. So if your patient is experiencing chest pain, you're going to have a set of standing orders you don't have to call the doctor for that you can work through. It's going to include things like putting the patient on oxygen. Do I care if their pulse ox is 97%? No, if they're experiencing chest pain, that means there is a lack of oxygen flowing to the heart. So my first priority is putting them on oxygen. Okay? Help that heart. What's my next priority? Maybe a chest x-ray. EKG, right? Start a line, yep, start an IV. Okay. Then I want to give them nitro, glycerin, and aspirin. Then we're going to look at our chest x-rays, getting some more labs, figuring out, okay, what's going on. EKG is super nice because they tell you exactly where the problem is and what's causing it. Like, oh, that's a myocardial infarction in this area of the heart. Now I have something to work with, right? Oh, they're in atrial fibrillation. That's why they're experiencing chest pain. Okay? Makes sense? Okay. All right, so let's take a quick break. It's 11:23. So let's come back at 11:35. Okay, take like 10 minutes, and we'll go over some review questions, some practice questions. Make sense? Fair? Okay. That wasn't so bad today, was it?
Do we have Sims later this afternoon?
We do have Sims this afternoon from 1 to 3.
Yeah, pero she made it more like interactive.
Gonna go out and no. That's what campus will tell you. But if you don't think you can come to the road, for sure shoot us a reminder.
Ay, ¿qué no? Como chino. Así neta.
Yeah.
That'd be easy. Yeah. Set the shortest.
Oh, yeah.
59,000. They raised it now, I would be making like almost 80,000. And I would have been a surgeon. I would have been making over it. They need to recheck their test if they fail.
Really?
Yeah. They should.
Why didn't you pay this beforehand instead of me going to stress over here with the high
Yeah,
tuition?
that's already. Like,
Yeah, they come.
Yeah, those suck.
I have a.
I don't like. From what I didn't study it. That was my
Oh, yeah, I think I know what you're talking about.
Yeah.
Yeah.
I knew her.
Dude, I was halfway here, and I was like, when you're like, are you gonna get coffee? I was like, I don't have time.
And I think my daughter's gonna go, and I told her, we're gonna go to prom.
And then I was like,
Carded in my uniform.
I tried to, but it's really don't care.
It doesn't matter.
She said to us, like, oh, I told her, I'm gonna go, no, you won't. Whenever she's here, she like.
No, wait for you to.
no, like, I'm girls, you can.
Yeah, it's hard to find the.
Yeah, so I was like, there's no way.
That's the thing, like, I'm gonna go check.
Oh, thank you.
That's what I'm saying, I have a legal document saying I have to be somewhere. No.
I have orders.
I can 49.
Yeah, whatever.
What do you pass by this?
Yeah, yeah.
The way that I went up there with you was like, do you have any fountain?
If they ask me, but
Come on and shoot.
Oh, man. Over it.
it's up to me, like, you don't want to do it.
That's why they bring all my
I went to the trailer.
You didn't go in with them.
They're rude.
All of the insurances.
Yeah, like they expect you to.
The insurance basically calls the hospital. Go and tell them, no, this is what we're paying.
Yeah. They have me the bill before they for the breakdown.
I didn't have to go. I didn't get that. I didn't get. You were like the watch this?
What?
Well, you know, I've only paid like 7, I don't know, like 5.
That's all my first pay was 7.
To you.
Yeah, just deliver at home.
I didn't see my hospital check. Because I had to order my food, what I wanted every night for like each meal.
Where they were like,
I
that's
had a private
$1,000.
Just playing up and I was like, skip.
I had like a queen size bed for myself.
That's what you get for being fancy. What'd you say?
Yeah. For your tax dollars.
Oh, me too.
But yeah.
Covered everything.
If all insurance. You also, I was watching a doctor, I think. Your doctor, I don't even have insurance. It's like, than it is for insurance. He's like, yeah, labs, for instance, if you need your insurance, they'll charge the insurance and they charge you like $200. You just pay it out of pocket, it's like $100. It's way cheaper.
Who teaches that?
I know they do already.
Oh,
I don't know, like if you had.
We did.
I got 50 grand. That's what they said. Because it's only 2 centimeters.
They have a reaction.
Yeah, you could still get it done though. Yeah. Oh yeah. $60,000.
It was out of the working.
No, I didn't like her.
She's like, no, you're gonna pass someone.
You guys are ready to go. Okay, this time you're looking at Jen this morning, so she said she'll just post the questions y'all are gonna go over, for you to look at and practice, and then any questions you have, you can just send to her. Okay. Yes, come back for the sim as of right now. Okay.